Hi everyone, it's me Ranjan as well. Today we will be discussing about abdominal aortic aneurysm. If you have to define an aortic aneurysm, it is an abnormal dilatation or bulging in the wall of aorta. Aorta is the largest blood vessel in the human body, responsible for carrying blood to the rest of the body. Aortic aneurysm is caused by the weakening and degeneration of the aortic wall. Though they can develop anywhere along the aorta, aneurysm most frequently occur in the thoracic portion called thoracic aortic aneurysm and abdominal portion called abdominal aortic aneurysm. While studying Fred's condition, the diagnosis is most likely to be abdominal aortic aneurysm. Now let's talk about normal anatomy and physiology of aortic wall. It consists of three distinct layers: tunica intima, tunica media, and tunica externa, also called tunica adventita. Under physiological condition, the tunica media and tunica externa are primarily responsible for bearing the hemodynamic load, the force exerted by the blood flow. The tunica media primarily provides distensibility, maintaining blood pressure, while the tunica externa provides a physical limit to expansion. Talking about pathophysiology, the development of abdominal aortic aneurysm in Fred's case includes different risk factors that include age, sex, comorbidities like hypertension. Talking about the disease itself, the other risk factors are family history, smoking, atherosclerosis, and obesity. Aneurysm forms due to complicated combination of mechanisms mostly driven by neovascularization, inflammation, and the breakdown of extracellular matrix as a result of chronic hypertension and injury. The pathophysiology of the disease is related to an initial arterial insult causing a cascade of inflammation and extracellular matrix protein breakdown by proteinases, leading to arterial wall weakening. The process of formation of aneurysm begins with neovascularization, that is the formation of new functional microblood vessels in the tunica media via the vasa vasorum. This could be initiated by hypertension causing injury to the aortic wall because of constant pressure or by genetic factors. Following neovascularization, inflammatory cells such as macrophages migrate into the vessel wall, releasing pro-inflammatory cytokines and matrix metalloproteinases that stimulate smooth muscle cells to produce more matrix metalloproteinases and other proteinases. The aortic wall contains a variety of biomolecules that helps to maintain the structure and function to the fascial, including elastin, collagen, and proteoglycans. Some studies have demonstrated that the walls of aneurysmal arteries have less elastin and collagen than normal arteries. This leads to breakdown of collagen and elastin, which stimulate the migration of more inflammatory cells, thereby setting up a cascade of aortic wall catabolism. As collagen and elastin are broken down, the wall weakens and more inflammatory cells are recruited, perpetuating a destructive cycle. The extracellular matrix continues to degrade because of this cycle, progressively weakening the aortic wall. The infiltrating inflammatory cells release chemokines, cytokines, and reactive oxygen species, which contributes to oxidative stress and tissue damage. Programmed cell death, also known as apoptosis, result in the loss of smooth muscle cells within the aorta, which severely compromises the aorta's ability to heal itself. Smooth muscle cells are responsible for producing elastin and other extracellular matrix proteins that maintain the integrity of the blood vessel wall. The aorta can no longer heal itself in the absence of enough smooth muscle cells, which speeds up the deterioration of structural proteins and encourages the development or growth of aneurysm. This is how an abdominal aortic aneurysm develops. The aneurysm gradually enlarges because of the combined effects of inflammation, matrix deterioration, and loss of smooth muscle cells function. The aneurysm expands as the aortic wall weakens, raising the possibility of rupture or dissection, leading to two potentially fatal consequences. So now let's discuss about the link between pathophysiology and Fred's case. The history of hypertension exerts pressure to the wall of the aorta, leading to stress and injury to the aortic wall. As a result of injury, there is neovascularization and migration of the inflammatory cells, majorly macrophages. This causes the production of chemokines and cytokines, which are pro-inflammatory mediators. This leads to oxidative stress and tissue damage, causing apoptosis of smooth muscle cells, which severely reduces the ability of the aortic wall to heal the injury caused by hypertension. This degradation smooth muscle cells in the aortic wall reduces the ability in producing connective tissue and repairing the damage to the wall, leading to decreased aortic wall thickness and ultimately forming the abdominal aortic aneurysm. Statin is a source of drug for aortic aneurysm. It falls under the class 3-hydroxy 3-methyl glutarate coenzyme A reductase inhibitors. The pathophysiologic collagenollytic pathway involved in the regression of abdominal aortic aneurysms plays significant role in the reduction in vascular inflammation. Statins may help stabilize pre-existing aortic aneurysms by reducing inflammation and preventing further aortic wall degeneration. Moreover, statins reduce the breakdown of collagen by maintaining the equilibrium between matrix metalloproteinases and matrix metalloproteinases tissue inhibitor, reducing the growth of abdominal aortic aneurysm. The synthetic lipid-lowering medication atorvastatin functions by blocking the enzyme HMG-CoA reductase, which is responsible for converting HMG-CoA into mevalonate, an essential precursor in the synthesis of cholesterol. Atorvastatin decreases the amount of cholesterol produced by the liver by inhibiting this enzyme. Additionally, statins have anti-inflammatory qualities that inhibit the breakdown of collagen and elastin by lowering inflammatory cytokine levels and macrophage activity in the aorta wall. So the indication includes minimizing low-density lipoprotein, atherosclerosis, hypertension, peripheral vascular disease, cerebrovascular illness, and also to lower inflammation and inhibiting further wall deterioration, which may help stabilize already existing aortic aneurysms. Some of the considerations that needs to be kept in mind while administering this drug as being nurses are serum level monitoring, which should be done 4 weeks after starting this therapy. Patients should be educated about the drug adherence and potential side effects of the drug like muscle pain and cramps, non-productive cough, difficulty in breathing, yellowing of the skin or eyes, and also the patient must be constantly monitored for any possible interactions with other drugs and other forms of interaction. Review for any special warnings and precautions for use. The plasma concentration of statin of the elderly people, especially over the age 65 years, should be accessed routinely. Advise patient to stop consumption of large amount of alcohol and caution if used in patient with a history of liver diseases, impaired renal and liver functions due to the risk of liver damage. Educate patient on monitoring of liver function test before and after the medication is commenced as suggested. Closely monitor blood glucose and renal function during statin therapy. Thank you.